Welcome back to the deep dive. Today we're shifting gears completely. We've pulled together the absolute core texts, the revision notes, and the classic papers to build something specific for a very particular listener.
Yeah, a very targeted session today.
Right, so if you are a plastic surgery resident, and especially if you're staring down the barrel of your board exams, whether that's the FRCS, the EBA-PRAS, or the American boards, this is for you. We are going straight into high-yield revision mode.
Exactly. We're stripping away the nice to know fluff. This is strictly need-to-know territory.
Just the facts.
Right. High-yield facts, the buzzwords examiners are actively listening for, and the safety concepts that, keep you from failing a BIVA. We're going to run this as a rapid-fire question and explanation session.
Exactly. So we're covering breast anatomy, reduction, and mastopexy. But before we crack open the textbook, a quick heads up. This deep dive covers the theory and the facts. But if you want to actually crush the oral boards, you need to know how to apply this to a patient sitting right in front of you.
Which is a totally different skill set.
It is, and that is exactly what we do in our clinical cases and journal club deep dives.
Yeah, you really can't pass on book knowledge alone. I mean, you need that clinical synthesis. So if you haven't upgraded to our premium feed yet, that's really where the rubber meets the road.
That's where you get the scenario-based training.
Exactly. So definitely go check that out.
And hey, if you pick up a single high-yield nugget today that helps you on exam day, do us a favor. Hit follow right now so you don't miss the next revision session. Drop a 5-star rating if you learned something, and leave a comment.
Yeah, let us know what you want to hear next.
Right. Specifically, tell us, do you want hand surgery or burns for the next topic? We'll literally let the comments decide.
The power is in your hands.
But right now, let's get to work. Let's start with the absolute foundation. Surgical anatomy.
The map of the territory.
Right. So in an exam, they might ask you to simply define the breast footprint. It sounds super basic, but you need to be precise.
Very precise.
So how are we defining those borders strictly for the exam?
Well, you need to visualize the chest wall boundaries. Vertically, we are strictly looking at the 2nd to the 6th rib.
2nd to 6th.
Right. That's your vertical span. Horizontally, you're going from the lateral margin of the sternum all the way over to the anterior axillary fold.
And there's a trap here, isn't there? Because if you just stick to that neat little rectangle, you miss something crucial.
Oh, absolutely. The axillary tail of Spence.
Right.
It extends superlaterally right up into the axilla. And if you forget that during, say, a mastectomy or a reduction, you are leaving tissue behind. Examiners love to check if you remember the tail because it tangibly changes the surgical field.
Okay, so we have the footprint. Let's cut a bit deeper. Internal structure. We know it's glandular, but how is it structurally organized?
It's essentially a compartmentalized system. You're looking at about 15 to 20 lobes, and they're all radiating out from the nipple like spokes on a wheel. But the structural integrity, the thing that actually gives the breast its shape against gravity that comes from the fibrous septa, these run from the skin all the way down to the pectoral fascia.
And in the upper breast, those are the famous suspensory ligaments of Astley Cooper.
Exactly.
Now, Astley Cooper is a name everyone remembers from med school. But there's another anatomical structure that has become the absolute darling of board examiners recently, the septum of Wöhringer.
Oh, yeah, this is a very high-value concept. If you want to look like you really know your anatomy, and especially if you're discussing modern reduction techniques, you have to nail this.
So what exactly is it?
The septum of Wöhringer is a thin, horizontal, fibrous septum. It's very distinct. It originates from the pectoral fascia right at the level of the 5th rib.
5th rib, okay.
And it travels partially through the breast, curving upward, and eventually it splits into medial and lateral ligaments.
So it acts like a hammock, essentially.
Yeah. In a way, yeah. Structurally, it anchors the breast to the sternum and the pectoralis minor. And this is why plastic surgeons really care about it. It's not just structural, it is a neurovascular highway.
This is the critical insight right here.
Yeah.
Why does Wöhringer matter to the surgeon holding the knife?
Because it carries the primary nerve supply to the nipple and the intercostal perforators.
The nerves and the blood.
Exactly. When you hear about surgical techniques like Hamdi's septum-based reduction, they are directly exploiting this specific anatomy to guarantee the nipple survives and keeps its sensation.
So if you respect the septum, you protect the supply.
It's really that simple.
Speaking of supply, let's do the plumbing. Arterial supply.
Yeah.
This is usually a classic list-making question in a written exam. What are the key vessels we need to rattle off?
You've got 4 main sources you need to list out. One is the internal mammary artery perforators.
Usually the biggest contributors, right?
Yeah, specifically the 2nd and 3rd. 2 is the lateral thoracic artery. 3 would be the lateral branches of the third, fourth, and fifth intercostal arteries. And 4,
The pectoral branches of the thoracoacromial axis.
you got it.
Okay, so that's the block. Now let's talk nerves. This is often a make or break safety question in Aviva. The examiner looks at you and says, "Doctor, where does this sensation come from?"
Well, it's a meshwork. You have the anterior cutaneous branches of the second to sixth intercostal nerves. You have the anterior cutaneous branches of the third to sixth lateral cutaneous nerves. And you even get some supraclavicular input from the cervical plexus up top.
That is the comprehensive textbook answer. But then the examiner leans in, they always do this, and asks, okay, but which one is the most important for the nipple?
That is the money question right there. The answer is the lateral cutaneous branch of the fourth intercostal nerve.
The fourth lateral cutaneous. Memorize that.
Absolutely. It enters the breast laterally and travels right through the gland to the nipple. If you're doing an inferior pedicle reduction or a lateral pedicle, this is the exact nerve you are trying to preserve to keep sensation intact.
Let's pivot from anatomy to aesthetics. We're marking a patient up in the pre-op area. We need landmarks. We often hear about Penn's ideal measurements. What are the numbers we should just have locked in our head?
Penn describes this perfect equilateral triangle. The base is the distance between the nipples, and the sides are the distance from the sternal notch to each nipple.
And the average distance.
On average, you're looking at about 21 centimeters for each side.
21 centimeters, that's the magic number. And what about the vertical drop? The distance from the nipple straight down to the inframammary fold, or IMF.
That's usually cited as 6.8 centimeters. Now, obviously, patients vary, but in a standard reduction, if you make that distance too long, the nipple rides too high on the mound.
Which looks unnatural.
Right. And if you make it too short, the nipple points down or it bottoms out. So 6.8 to 7 centimeters is generally the sweet spot for a well-proportioned breast.
And what about the areola itself?
Between 3.8 and 4.5 centimeters in diameter. Anything larger than that usually looks out of proportion on a reduced breast. You use a cookie cutter marker to ensure this is perfectly exact.
But before we get into the actual surgery, I want to touch on something that confuses a lot of junior residents, and honestly probably half the general population: bra sizing.
Oh, bra sizing.
Specifically, the UK system, it's a mathematical formula, right? It's not just random guessing in a fitting room.
It feels like random guessing sometimes, but yes, there is a rigid formula. It's a two-step process. First, you get the band size. You measure the circumference of the chest right at the inframammary fold.
Right under the breast.
Exactly. You take that number in inches, and you add 4 or 5 to get to the nearest even number.
Wait, hold on. You add inches. So if someone measures 31 inches around their ribs, they are a 36 band.
Exactly. 31 plus 5 is 36. If they measure 32, you just add 4 to get 36. It's an archaic system based on old fabric stretching standards, but that's still the rule.
Okay, and the cup.
The cup is the delta. It's a difference between that band size, the calculated one we just did, and the circumference at the fullest part of the breast.
So you subtract them.
Right. If the difference is less than 1 inch, it's a double A. 1 inch is an A cup, 2 inches is a B, 3 is C, 4 is D, 5 is DD.
Simple enough when you explain it like that. Okay, let's get into the operating room. Section 3, breast reduction.
The workhorse of plastic surgery.
It really is. And the history of reduction is fascinating because it's basically a timeline of surgeons trying to solve the problem of scarring versus vascular safety.
That's a great way to put it.
Let's do rapid fire history. I'll give you the name or the era, you tell me the contribution. Let's start way back in the 1920s.
Thorek.
Thorek is the nuclear option, the free nipple graft. He realized that for truly massive breasts, you just couldn't rely on the blood supply stretch that far, so he just took the nipple off completely and put it back on as a skin graft.
Jump to the 1950s. WISE. The WISE pattern. This is the classic anchor or inverted T skin incision. He figured out the geometry of coning the breast using a keyhole pattern. This is still the most common skin pattern used today.
1960.
Strumbeck. The horizontal bipedicle. He kept the blood supply coming from both sides horizontally.
1963.
Skoog. The lateral pedicle. He tried to bring the supply in from the side.
1972.
McKissick. The vertical bipedicle. Supply from the top and the bottom.
1975. This is a massive name in the field.
Ribeiro.
Ribeiro completely changed the game with the inferior pedicle. This became the gold standard for decades. You rely on that central mound of tissue attached to the chest wall inferiorly. It's safe, it's highly reliable, and it works for most shapes.
But then surgeons and patients started hating the scars. We wanted to get rid of the horizontal scar in the fold. Enter the vertical revolution, le jour.
Right. Lejour, and we really should credit Lassus, who described it earlier, popularized the vertical scar technique. No horizontal incision at all, just a lollipop shape. She relied heavily on liposuction and natural skin retraction to handle the excess envelope. And then Hull Finley in 1999.
She refined the vertical technique by adding a medial pedicle. This is a very elegant operation. You get the aesthetic benefits of the vertical scar, but with a very robust blood supply from the medial side.
And finally, bringing us full circle back to the anatomy we started with, Hamdi in 2005.
Hamdi goes back to the septum of Röhringer. He described using that septum specifically to preserve the supply to the nipple areolar complex, or NAC.
It's an amazing evolution from just cut the nipple off to this incredible microsurgical understanding of septal anatomy. Now, for the exam, we need to classify these techniques. Usually we group them by skin incision or by pedicle type. What are the big buckets for skin excision?
You have the Wise pattern, that's your inverted T. You have the Rednall, which is a B shape, kind of an offset anchor. You have the vertical pattern, like le jour. And for very small reductions, you have the Benelli, which is just a donut or a periolar excision.
Let's drill down into the pedicles then. This is arguably the most important technical section for a resident. Let's start with the inferior pedicle. It's the one most residents learn first. Why is it so popular?
Because it's incredibly forgiving. It has a robust vascular supply, and because you leave a wide base, you aren't usually sweating about nipple necrosis. Plus, it's great for preserving sensation because it captures that fourth lateral cutaneous nerve we talked about.
Okay, so if I'm a resident performing my first inferior pedicle reduction, what are the do not cross rules?
Yeah.
I want the technical commandments.
Commandment 1. The pedicle must stay attached to the chest wall. Do not undermine it. If you lift it off the muscle, you've cut the blood supply.
Makes sense.
Commandment 2. You can incline the base laterally. A lot of surgeons do this to be able to capture that sensory nerve.
Right.
Commandment 3. In a very firm glandular breast, you have to be careful with the closure. If you force the pillars together, you can get tension. You might need to narrow the width of your keyhole pattern to relieve that strain.
And commandment 4.
Watch the nipple height. The NAC should sit just below the most prominent part of the projected breast. If you put it too high, it looks terrible, and it's an absolute nightmare to fix.
Now contrast that with the medial pedicle, specifically the Hull Finley style. How does that differ technically?
It's a totally different philosophy. With the patient sitting up, the markings actually look like a supraremedial pedicle. But intraoperatively, you are creating a full-thickness pillar of tissue dermis and gland straight down to the chest wall. You do not expose the pectoralis fascia under the pedicle.
So the pedicle itself forms the internal structure.
Exactly. The inferior border of your pedicle actually becomes the medial pillar of the new breast. You stitch the lateral tissue to it, coating the breast around this live pillar. The skin just redrapes over the top.
It sounds like it gives better shape.
It gives a lot of projection, whereas the inferior pedicle can sometimes bottom out over time.
And when do we admit defeat and go for the Thorek method, the free nipple graft?
I wouldn't call it defeat at all. I'd call it safety prioritization. You use this for gigantomastia when you're removing massive amounts of weight, say over 1,500 or 2,000 grams per side,
Right.
or in older patients with significant comorbidities where you just want to minimize operative time and risk.
What's the trade-off for the patient?
You lose projection, the nipple looks flat like a sticker, you lose all sensation, and you have the risk that the graft just doesn't take, leaving you with a wound. But you avoid the risk of a heavy pedicle kinking and dying, which is a much, much bigger problem.
Let's move to section 5, mastopexy, the breast lift. Before we cut, we have to diagnose. How do we classify the droop?
We use Regnall's classification of pindicus. You need to know this cold for the boards. It's all about the relationship between the nipple and the inframammary fold.
Walk us through the grades.
Grade 1, or first degree. The nipple is at the exact level of the IMF. It's dropped, but it's not below the fold yet.
Okay.
Grade 2. The nipple is below the IMF, but it's still sitting above the lowest contour of the breast gland.
So it's pointing straight ahead still, mostly.
Yes. Grade 3. The nipple is below the IMF, and it is the lowest point of the breast. It's basically looking at the floor.
And then there's the trick question, pseudoptosis.
Pseudoptosis is when the breast gland itself has dropped. It looks saggy, the volume is low in the lower pole, but the nipple is actually still sitting at or above the IMF. You see this a lot in postpartum women or after massive weight loss.
Why is that distinction so critical for the exam?
But because if you treat pseudoptosis like grade 3 ptosis, you're doing the wrong operation. Pseudoptosis often just needs an implant or auto-augmentation. It doesn't necessarily need a massive skin excision.
That brings us to correction. Can we just put an implant in to fix a lift?
Ah, the fill the envelope strategy. For very minor ptosis, sure, an implant can take up the slack, but for real ptosis, using an implant alone is a trap.
You end up with the Snoopy nose deformity.
Or the double bubble.
Yeah.
The implant stays high on the chest wall, and the loose breast tissue just droops off the front of it. It looks awful.
So we need to tighten the skin envelope. We have the perioral purse string.
The round block. You cut a donut of skin around the areola and cinch it closed. It's great because the scar is totally hidden around the areola. But the downside is it flattens the breast, you lose projection, and over time, the areola tends to widen out again because of the tension.
So if we need more lifting power, we add the vertical scar.
Right, the vertical limb allows you to remove a lot more skin horizontally and really cinch the lower breast tight. This is the workhorse for most modern mastopexies.
And for the severe cases.
You go back to the anchored, the inverted T. If there is just too much skin, both vertically and horizontally, you absolutely need the horizontal incision in the fold to manage it.
There's also the L-shaped scar mentioned in the literature sometimes.
Yeah, it's a compromise. You remove the medial part of the horizontal scar. It tries to limit the scar burden, particularly in the cleavage area, but it can be tricky to get a smooth shape. It's mostly for mild to moderate cases.
Let's wrap up with the part no one likes but everyone needs to know. Complications. You're sitting in the clinic, consenting a patient for reduction. You need to quote numbers. What are the specific stats?
Let's break it down by timing. Early complications. Number 1 is altered sensation. About 20% of patients will have some sensory change.
Temporary or permanent?
Usually temporary, but sometimes permanent. Hematoma bleeding afterward is about 1%. And the disaster scenario nipple necrosis is thankfully rare, less than 0.5% in standard reductions, though it's much higher in smokers or massive reductions.
And later on, what are the latent complications?
Wound healing issues are common, maybe 5%, especially at the T-junction where the scars meet. You can get fat necrosis, hard lumps in the breast. And aesthetically, you worry about asymmetry in dog ears, those little bunches of skin at the extreme ends of the scar.
There's one long-term issue that I think is absolutely vital for counseling young patients.
Breastfeeding. This is huge. The literature varies, but some studies suggest up to 50% of women may have difficulty breastfeeding after a reduction. If a patient is planning a family, you have to have a very honest conversation about this. You simply cannot promise she'll be able to nurse.
That's a crucial counseling point. Okay, we have covered a massive amount of ground today, from the ribs to the nipple, from the 1920s to the 2000s. If our listeners walking into the exam hall tomorrow morning, what are the top 3 takeaways they absolutely cannot forget?
Number 1, the septum of Wöhringer. Know that it carries the nerves. It is the anatomical basis for modern techniques.
Got it.
Number 2, the 4th lateral cutaneous nerve is the primary sensation to the nipple. Memorize that specific nerve. And number 3, Regnault's classification. You will be shown a photo in the Viva and asked to grade the ptosis. Know the difference between grade 2 and pseudoptosis.
Fantastic summary. Look, this was a high-speed review of the facts. But the board exam isn't just about facts, it's about clinical judgment. You know, Mrs. Jones has diabetes and smokes and wants a reduction war. What do you do? To hear how we handle those real-world scenarios, you need to listen to our Clinical Cases Deep Dive. It's on the premium feed.
That's where we actually apply all this theory. That is where you learn to be a consultant. Go subscribe now. And please, if this helped you organize your revision, leave us a rating. It really helps other residents find the show.
In the comments, let us know. Hand surgery or burns for the next revision deep dive. We'll let you decide.
I'll leave you with one final thought to mull over. We've seen this history move from the wise pattern to the vertical scar to minimize the footprint on the skin. But there is a trade-off. As we reduce the scar burden, are we sometimes compromising our ability to reshape the breast cone effectively? It's the eternal tension between shape and scar.
Something to think about. Good luck with the studying, and we'll see you in the next deep dive.